The last speaker in this session is Professor Anne Greenough. Professor Anne Greenough is one of the international known figure in neonatal respiratory medicine. Professor Anne Greenough is the Dean of the Faculty of Medicine at King's College of London, the Chairman of NIHR, National Specialty Group in Pediatric Research, and Professor in Neonatology and Clinical Respiratory Physiology at King's Hospital. Professor Anne Greenough, she has more than 600 published paper and book chapter. Professor Anne Greenough will speak about the optimization of neonatal ventilation. Please.
Thank you very much indeed for that very warm welcome and all the hospitality that my husband and I have been shown since we came to Dubai. I'm very honoured to be asked to give you this talk. As you've heard, I'm going to talk about optimization of neonatal ventilation. This is a young lady who's got bronchopulmonary dysplasia, and this is the most common adverse outcome of being born very prematurely. She may remain oxygen dependent for months, if not years, and may face a lifelong legacy of increased respiratory morbidity. As this audience is well aware, bronchopulmonary dysplasia has a multifactorial etiology, yet of course mechanical ventilation has a part to play, and therefore optimization of neonatal ventilation with the hope of reducing BPD is of paramount importance. There has been much research done to optimize neonatal ventilation, and I'm afraid there is so much I cannot hope to go through it all with you today. So forgive me, I'm going to pick out publications that are giving key facts in this jigsaw, and I apologize if I miss out something that you have published. No offense meant at all, just paucity of time. The ventilator strategies have fallen into three different groups. Avoidance of intubation and mechanical ventilation, for example, using nasal CPAP, respiratory support working synergistically with the infant's respiratory effort, patient-triggered ventilation, and minimization of excessive tidal volumes, otherwise volume-targeted ventilation or high-frequency oscillation. For a number of years, we had many reports showing that CPAP was associated with a reduction in bronchopulmonary dysplasia. But those reports were largely case series, comparison with historical controls. Nevertheless, many neonatologists were convinced and were not in equipoise to undertake randomized controlled trials. Thankfully, more recently, those RCTs have been undertaken. There have been 6 randomized controlled trials looking at the so-called INSURE technique, early surfactant, and then extubation onto CPAP versus a selective surfactant when the infants developed respiratory distress syndrome. And what the meta-analysis of those 6 trials have shown is the INSURE technique reduced BPD, reduced the need for ventilation, and reduced air leaks. But the amount of surfactant use, or the amount of babies given surfactant, was significantly greater. And that causes a problem in interpreting these results. Because for many years we've known that early versus selective surfactant reduces air leaks, the combination outcome of BPD and death, and improves survival. So was it use of CPAP or was it use of early surfactant in those studies? Well, 3 subsequent studies have really tried to further unravel this mystery. The first is the COIN trial, reported by Colin Morley, that randomized 600 infants between 25 and 28 weeks of gestation. He was able to show a reduction in oxygen dependency at 28 days and a modest but significant reduction in the duration of ventilation. But oxygen dependency at 36 weeks was not reduced, and in the CPAP group, was a 3-fold increase in pneumothorax. And I'm sure on your units you do not see 1 in 10 babies getting pneumothoraces. So this was a very disappointing result, perhaps explained by the lower use of surfactant in the CPAP group or the 8 centimetres of CPAP that was used. The other 2 studies had similar designs. This is again in very immature infants, prophylactic surfactant with Curasurf, and extubation within an hour, so an inshore technique, versus again selective surfactant when CPAP failed. Interestingly, nearly 50% of the infants in that group required surfactant by a median of 4 hours. When we look at the primary outcome, mechanical ventilation within the first 5 days, there was no significant difference. A tendency to more pneumothoraces in the prophylactic group, but no significant difference in any of the outcomes. In the second study, which was very large, over 1,000 infants, although they intubated and gave surfactant within an hour of birth, extubation could be within 24 hours of birth. CPAP at a level of 5 centimetres of water was used, again with rescue surfactant in the first 48 hours. Not surprisingly, in the surfactant group, more infants were ventilated in the delivery suite, more infants got surfactant, but the primary outcome did not differ between the 2 groups. The CPAP group had fewer days of ventilation, but of course they would do, but they were more likely to be alive and not ventilated by day 7. And as you can see, that's highly statistically significant. So what does this tell us? Well, it tells us, all of these 3 studies, that perhaps CPAP is just as good as ventilating babies in the labour suite. But I think it also makes another important point, and that is perhaps we do not need to be giving all babies surfactant in the labour suite, but actually we can wait for a few hours till they're developing respiratory distress. And clearly that would be very cost effective. Sticking with other forms of ventilation delivered by nasal prongs, this is one of the studies looking at synchronized nasal IPPV. So the infant's respiratory efforts were picked up using the Graysby capsule. And what this showed in these infants who were very immature, and it's a large study, that in babies of 500 to 750 grams, the combined outcome of BPD was significantly reduced, as was BPD. But there were no other significant differences, and no significant differences in other birth weight groups. And this is a non-randomized retrospective review. So I think really doesn't give us too much information or persuades us to use SNIPPV. There have been 3 RCTs looking at nasal IPPV, so delivering ventilation through a nasal prong, but with no attempt to synchronize with the infant's respiratory efforts. And this was compared to nasal CPAP, and this was from birth. And what you can see is that NIPPV was associated with a significant reduction in the need for invasive ventilation in the first 72 hours. But again, no difference in the incidence of BPD or other outcomes. Now, many colleagues are using these modes to try and facilitate babies to stay off the ventilator after extubation, but similar randomized controlled trials have not been undertaken. If we now move on to triggered ventilation, this is our meta-analysis that's reported in the Cochrane Review. No significant difference in oxygen dependency, no matter how defined, severe intraventricular hemorrhage, and a non-significant trend towards an increased mortality in the triggered mode. But what that meta-analysis does emphasize, that if you use trigger ventilation, i.e. assist control triggering on every breath, or SIMV triggering on a predetermined number of breaths, then there is a reduction in the duration of ventilation, but only when PTV is started in the recovery phase. So these modes are weaning modes rather than modes that should be used in the acute phase of the infant's respiratory illness. Now, since those studies, we've developed more sophisticated modes of triggering. And one of those is pressure support, which again can be triggers on every breath and can be used with volume-targeted ventilation, SIS control, or SIMV, or SIMV. And in this study, there was a comparison between SIMV versus SIMV plus pressure support. This was a study by Reyes and comes from Bancalari's group. And it was 100 infants who were all very small and all ventilated beyond the first week of life. In all infants, you can see that when pressure support was added to SIMV, there is a reduction in the proportion of infants who were ventilated at 28 days. And in the bigger babies, a reduction in the duration of oxygen dependency. So this tells us adding pressure support to SIMV is better than SIMV alone. And we would speculate that that is because we're triggering, the baby is receiving support on for every breath, and that is reducing the work of breathing. We did a study to test that hypothesis, and we used SIMV and pressure support in exactly the same way in Reyes' trial. We looked at 20 infants who were being weaned from mechanical ventilation, and we measured the work of breathing using the pressure time product, which I described to some of you in detail yesterday. And what you can see, the two modes of ventilation, there are similar blood gases, but you will see that when we add pressure support, we reduce the work of breathing, and this is because the infant is breathing less. They're getting more support from the ventilator. We've recently completed a study, a randomized study, comparing whether assist control or pressure support would be a better form of weaning. We hypothesized that pressure support would be more advantageous because we're limiting the inflation time to a very tight window, and so there'd be less asynchrony, less active expiration. But assist control, on the other hand, might be better because there's usually a longer inflation time, therefore likely a lower work of breathing and perhaps increased respiratory muscle strength. We tested those hypotheses in 36 infants, both term and preterm, who were at weaning criteria. Pressure support, the inflation time, was kept between 0.25 and 0.3 of a second. Now, we did that by altering the termination sensitivity, which, as you know, cuts the inflation up higher up the infant's breath as you increase the termination sensitivity. To our surprise, the termination sensitivity, the maximum of 15%, was not tolerated. And in some ventilators, they only allow a termination sensitivity of 15%. And indeed, the majority of infants, we were only able to use a termination sensitivity of 5% if we didn't want the inflation time to be lower than 0.25 of a second. We found in our randomized groups the duration of weaning was not significantly different, and indeed we found no significant differences in our physiological outcomes, the work of breathing, the respiratory muscle strength, and the degree of asynchrony. The reason for that was there were no significant differences when we looked at the airway pressure waveforms and inflation times. So essentially, with assist control and pressure support with attention to the inflation time, we are delivering the same modality, and both are efficacious weaning modes. Proportional assist, I used to say, is the Rolls-Royce or the Mercedes of neonatal ventilation, because, of course, during proportional assist, the applied pressure is servo-controlled throughout each spontaneous breath, meaning that the frequency, timing, and magnitude of lung inflation are controlled by the patient. Also, during proportional assist, you can turn up the degree of unloading. You can increase the respiratory support to overcome the elastic and resistive abnormalities of the infant's lung function. So a dual win, so to speak. This is a figure taken from one of Andre Schultz's paper. This is the flow, but if we concentrate on these two traces, this is esophageal pressure and this is airway pressure. And remember that the machine faithfully follows what the infant does. So as the infant breathes harder, the machine feels the baby's lungs have got stiffer and delivers more pressure. As the infant breathes less, the ventilator assumes that the baby's lungs are getting better and delivers less pressure. Now, clearly, when infants start to breathe less deeply, it does not necessarily mean they're getting better. It could mean they're getting tired. yet the machine will slavishly follow this. And therefore, if the baby goes apneic, it's essential that there's an effective backup rate, which has been a problem. Andrew Schulze has published 2 clinical studies, both with the same design. They're crossover studies, one in acute RDS and one in infants with evolving BPD, which I show you here. They both have the same message. The blood gases were maintained, as shown by the inspired oxygen here, at lower pressures on PAV than PTV, suggesting it's better. But there were a greater number, and therefore longer, desaturations on PAV, showing that the backup rate and the setting of it is critical. We're currently in the middle of a number of clinical studies looking at proportional assist ventilation, but we were very concerned that we really understood this technique before we went into clinical practice. So my husband, Anthony Milner, with a series of research fellows, has undertaken a number of in vitro studies, and this is just one of them. This is using the Stephanie ventilator, and what my husband did was create dynamic lung models which had the same abnormal lung function as RDS, BPD, and meconium aspiration syndrome. And regardless of which model, they got similar results. Yes, when the unloading was increased, the inspiratory load was reduced. But the ventilator overshot and gave more pressure than was needed to compensate for the infant's respiratory abnormalities. And perhaps more concerning, that when we were trying to compensate for the resistance of the models, if we got it wrong, the unloading was too great, then there were oscillations in the airway pressure waveform. And additionally, there was something which we used to call the trigger delay. The infant made a respiratory effort, and it took the ventilator 60 milliseconds to respond. So during that time, the baby is receiving no respiratory support, and clearly that increases the work of breathing. This is what happens when you get the unloading incorrect or too much. These are the oscillations that happen in the airway pressure waveform. Now, the clinical significance of these we don't know, but as you can see, these are occurring in expiration as well, and likely, therefore, to stimulate active expiration. So if one's going to use PAV, it's absolutely critical to have the right level of unloading. Now, I said I thought PAV was the Rolls-Royce or the Mercedes of triggered ventilation, but now I'm convinced this technique is neurally adjusted ventilatory assist. We haven't yet got randomized trials in neonates, but we've got a whole series of case reports, and this is just one of them. 26 infants were involved in this study, but for a variety of reasons, only 19 completed the crossover study. 4 hours on SIMV with pressure support and 4 hours on NAVA. And what you can see is that the NAVA, there was less peak pressure, lower work of breathing. Now, for those of you not familiar with NAVA, what happens is there is a catheter pushed down, which is a nasogastric tube, on which there is a montage to detect the EMG signal of the diaphragm, and the montage sits above and below the diaphragm. And so as the baby makes inspiratory efforts, the EMG signal is used to trigger the ventilator. And so this work of breathing is lower because it absolutely, faithfully maps on to what the infant's respiratory efforts are doing. Moving on to volume-targeted ventilation. This is the latest meta-analysis in the Cochrane Review, which shows that volume-targeted ventilation appears very superior to pressure-limited ventilation, a reduction in the combined outcome of death or BPD, less duration of ventilation, less pneumothoraces, severe intracranial pathology, and less hypercarbia. But this meta-analysis is made up of studies of very different design, very different ventilators, and indeed, in some of the earlier studies, the pressure-limited ventilators were very inferior to those by which volume-targeted ventilation was delivered. So I think we have still a whole series of questions to ask about volume-targeted ventilation, not least which ventilator, which babies, what level of volume targeting. This is one of the better studies in which in both arms the same ventilator was used. Only 90 infants, and so their primary outcome was a combination of oxygenation related to mean airway pressure. There were no significant differences in that primary outcome until the researchers did a sub-analysis and found it was significantly reached sooner in the volume ventilated group in babies less than 1,000 grams, but no significant differences in any clinically important outcomes. And what the researchers did was used 4 to 6 mils per kilo. They said they used that range because that's the tidal volume range. But what it begs the question is 4, 5 or 6 better for babies, and in which conditions? A number of us have used physiological outcomes to try and answer that question. For paucity of time, I'm just going to walk you through our studies. This is a study, again, using pressure time product, the work of breathing. And in this study, Dina Patel has looked at babies during weaning. Half of them were on ACV, half of them are on SIMV. This and the next 2 studies had the same study design, so I'll walk you through it. We start at baseline with no volume targeted, and then the infants are randomized for 1 hour on 4, 5, and 6, then go back to baseline, then randomized again, and so on. But for simplicity, I've shown you it as 0, 4, 5, and 6. What you can see is when we put on the volume targeted level of 4 mils per kilo, the work of breathing goes up significantly and only comes down when the volume targeted level is 6 mils per kilo. The same is true of SIMV, but you will see at every level of volume targeting, the work of breathing is higher on SIMV. Again, as yesterday, further emphasizing that SIMV is usually poor for small babies. This is another study that Dina did, and this is looking at babies with acute respiratory distress. So they were studied after surfactant and in the first 48 hours. Again, the same finding. 4 mils per kilo of volume targeting in these babies in the acute stage increases the work of breathing, which only comes below baseline at 6. And this is a study by another of our MD Res students, Ollie Chowdhury, and this is one of a few studies that are reported in term-born infants with a variety of diagnoses other than congenital diaphragmatic hernia. And despite the fact these are all term babies, putting on volume targeting 4 mils per kilo increases the work of breathing, which comes down in all of the babies between 5 and 6 mils per kilo. So in preterm, with acute respiratory distress, with weaning, and in term babies, 6 is better than 4, and other physiological outcomes studies have shown exactly the same. As a consequence, when we undertook this randomized trial of VTV versus pressure-limited ventilation, we used the higher volume targeted levels, and in both arms, we used the same ventilator. Our hypothesis was that compared to pressure-limited ventilation, volume-targeted ventilation would reduce the time to weaning criteria. So we're studying babies from the acute stage of the illness to when they reach weaning, not throughout their career. And our aims were to determine whether any effect we saw was due to differences in the work of breathing or respiratory muscle strength. Because we'd optimized the delivery of volume-targeted ventilation, we assumed we would reduce the work of breathing and hence increase respiratory muscle strength in that arm. This is a Kaplan-Meier plot of the time to reduce weaning. I am colourblind, so I don't know which are the red and the blue lines, but I don't think I need to tell you because you can see they overlap. There was no significant difference between the two groups with regard to the time to weaning. And indeed, when we looked at the physiological outcomes, be it the work of breathing, be it the inspiratory pressure or the expiratory pressure, measuring inspiratory or expiratory respiratory muscles, there was no significant difference between the two groups. However, when we looked at our secondary outcomes, and we have a number, and I emphasize though not 20, you will see that there is an important difference in these infants with acute respiratory failure, significant less hypercarbia. Moving rapidly on to rescue oscillation, and I will go very fast through this, there is, in this study, we've looked at, this is preterm infants with severe respiratory failure. Oscillation group, less air leaks, but more intracranial hemorrhage. 2 trials in infants with severe dysfunction respiratory failure, elective and a rescue, no significant differences in any of the primary outcomes in those two trials. Prophylactic oscillation, a significant reduction in BPD, no significant adverse effects, in particular intracranial pathology. This again is a meta-analysis that's apples, oranges and bananas. Hence in the United Kingdom, we did the United Kingdom Oscillation study in which we randomized infants in the first 60 minutes and they had to be on their randomized mode in that hour. No significant differences in any outcomes. And when we looked at lung function at a year, again, no significant difference. So we've conclusively proved prophylactic oscillation doesn't work. Afraid not. This is a subset of the babies, perhaps an eighth of the babies in the UCOS trial. And although we've done a lot of measurements, we haven't measured small airway function. And we now know that's increasingly important in premature infants. This is a study from Janet Stock's group, and what it shows you is that at birth, these infants who were all 32 to 35 weeks, no respiratory distress, had normal lung function using the squeeze technique. Over the first months, they deteriorate with no other intervention or insult. This is a study looking at infants with BPD in whom they used oscillation in the smallest and sickest from birth. They were identified retrospectively, prospectively followed at 6 and 12 months. And again, they measured small airway function. And the infants who'd received CMV, conventional ventilation, initially deteriorated as we would have expected from the previous slide. The oscillation group do not, so at a year they have significantly better lung function, suggesting oscillation protects small airway function. I emphasize this isn't a randomized trial, and what we need is to follow up randomized trials, and I'll come back to that shortly. What I just want, with the chairman's permission, is just 2 or 3 slides on term-ventilated babies, because these are a forgotten population, and I want to emphasize to you they're important. We ventilate between about 3.6 per 1,000 term babies per year across the globe. That amounts to 35,000 infants per annum in the USA. We've recently looked at consecutive infants, term-born infants without congenital anomalies, looked after on our unit. A quarter developed seizures, a quarter had severe neurodisability at follow-up. These were not babies with severe HIE, I emphasize. The adverse outcome, i.e. died or had severe neurodisability, was a requirement for anticonvulsants, but interestingly, ventilation for only more than 3 days. I defy you to find me more than a dozen papers, randomized papers in the literature that have looked at term-born infants. Yet when we therefore asked what was going on in the UK, we found as initial ventilation mode, tertiary neonatal units compared to local neonatal units were likely to use oscillation for meconium aspiration and pulmonary hypertension, and particularly as rescue mode for meconium aspiration syndrome. That is on one study alone. So I wonder, how we all feel so confident about using oscillation. My last 3 slides, Chairman. Congenital diaphragmatic hernia. I certainly feel these babies are our most challenging to ventilate. This baby's got a right-sided diaphragm, liver in the chest, left-sided pneumothorax. Baby on our unit, I'm pleased to say, is alive and well. Because they are so challenging, a group of us have got together in Europe, across European countries, to form the CDH Euro Consortia. And our aim was to form a consensus, a way of managing these babies, so then we could use interventions on a stable baseline. We agreed we should intubate immediately after birth, not use bag and mask. We should use low pressures as possible. Some said less than 25 centimeters. Some of us were more pragmatic. We all agreed not to use surfactant because both in term and preterm infants with CDH, it increases mortality and BPD. We disagreed about CO2. Some wanted permissive hypercapnia, but we finally agreed with the powers of persuasion, 45 to 60. And on that baseline, what we realized was there was no information to really suggest should we oscillate or put CDH infants on conventional ventilation. And so we're currently, across Europe, doing the Vichy trial, in which we're randomizing 400 infants to either oscillation or conventional ventilation at birth, and we're halfway through it. So in conclusion, ladies and gentlemen, I hope I've emphasised to you the impact of the newer modes need to be determined after delivery has been optimised. For example, determining the optimal level of volume targeting for each condition. All studies should incorporate long-term outcome. BPD is not a good surrogate. Babies without BPD can suffer long-term respiratory morbidity. And coming back to prophylactic oscillation, I'm delighted to say the NIHR in the United Kingdom has funded a very large study for us to follow up the babies from the UCOS study, and at 12 they're undergoing comprehensive cardiopulmonary and neurological assessment at King's College Hospital. And so we will know in 3 months' time whether indeed prophylactic oscillation does protect small airway function and the true risk-benefit ratio. I'd just like to finish with some acknowledgments, our funders, the various MD Res students, and the ones I've mentioned, but there are many, many more. Jed Rafferty, my non-clinical senior lecturer, and particularly Anthony Milner, my husband, who's developed many of these physiological techniques I've told you about, and that I'm an NIHR senior investigator. Thank you very much for your attention.